In this video, the Cubital Fossa and Flexor Forearm will be presented. To begin, I would like to revisit the osteology of the elbow joint, since we'll be referencing several of these bony landmarks as they relate to the muscles of the forearm. As you may recall, the elbow joint has three articulations. The trochlear notch, shown here, participates in a hinge-like movement around the trochlea of the humerus, which is shown here. Here's the trochlea indicated by the X. And recall that the coronoid fossa, above the trochlea of the humerus, receives the coronoid process, which is the anterior extension of the trochlear notch. The coronoid fossa receives the coronoid process when the forearm is in full flexion. And likewise, the head of the radius, shown here, articulates with the capitulum of the humerus, which is a ball or knob-like structure at the distal end of the humerus. The radial fossa, located just proximal to the capitulum, receives the head of the radius when the forearm is in full flexion. As was presented previously, the biceps brachii muscle attaches to the radial tuberosity shown here on the proximal radius. And recall that the biceps brachii participates in both flexion of the forearm as well as supination of the forearm. The ulnar tuberosity shown here, which is not nearly as pronounced as the radial tuberosity, is the site of attachment for the brachialis muscle, which also flexes the forearm. For the purposes of today's presentation, the medial epicondyle of the humerus, shown here by the triangle, represents the site of attachment for the common flexor tendon. We'll discuss this more in just a moment. And lastly, I'll also point out the medial supracondylar ridge, shown here. This happens to be the site of attachment for the humeral head of the Pronator teres muscle, which is one of the muscles of the flexor forearm. Before presenting the muscles of the flexor forearm, I first want to discuss the contents of the cubital fossa. The cubital fossa is a triangular-shaped depression on the anterior side of the elbow, shown here by the yellow highlight. The cubital fossa is bound by the brachioradialis muscle laterally, shown here by the X, and bound by the pronator teres muscle medially. And above, it is bound by an imaginary plane, represented by this dotted line, which connects the medial to the lateral humeral epicondyles. On this image, you can faintly see the epicondyles here in relief. The floor of the cubital fossa is bound by the brachialis muscle, shown here just deep to the biceps brachii muscle. I'll also mention to a lesser extent the supinator muscle, shown deep here within the fossa, also forms the boundary of part of the floor of the cubital fossa. The roof of the cubital fossa is bounded by skin, fascia, and the bicipital aponeurosis, shown here. In addition, I'll point out that the bicipital aponeurosis also separates the superficial structures of the cubital fossa from the deep structures of the fossa. Notice here in the lower right image that the superficial veins and the cutaneous nerves overlie on top of the antebrachial fascia and on top of the bicipital aponeurosis. For example, here's the lateral cutaneous nerve of the forearm, which was the cutaneous branch or continuation of the musculocutaneous nerve. And similarly, here's the medial cutaneous nerve of the forearm. In addition, we have the median cubital vein, which is this small vein here in the antecubital fossa, connecting the cephalic vein to the basilic vein. Recall that the cephalic vein courses along the lateral aspect of the forearm, while the basilic vein courses along the medial aspect of the forearm. The median cubital vein is an important site clinically because it's an area where the median cubital vein is of clinical importance because it is a common site for venipuncture to either withdraw blood from or to administer fluids or drugs intravenously. Two very important structures passing through the deep cubital fossa are both the brachial artery and the median nerve, shown here sitting adjacent to one another. Notice again how this nerve-artery pair courses deep to the bicipital aponeurosis. and they also course deep to the median cubital vein. If during venipuncture the needle is inserted too deep through the back of the median cubital vein, one runs the risk of puncturing the brachial artery or even hitting the median nerve. This is why this first line of protection, called the bicipital aponeurosis, is so important. And lastly, I would like to point out that the radial nerve, shown here, also courses through the cubital fossa along its lateral boundary, between the brachioradialis muscle, shown here, and the deeper brachialis muscle, shown here. Here within the cubital fossa, the brachial artery coursing through the arm terminates as both the radial artery, shown here, and the ulnar artery, shown here. The radial artery runs down the lateral side of the forearm, and it can be palpated near the wrist. The ulnar artery courses down the medial aspect of the forearm. Surrounding the elbow joint are a number of collateral vessels, which supply blood to the forearm when the forearm is in full flexion. As you might imagine, when the forearm is in full flexion, diminished blood flow occurs through this area of the brachial artery and the radial and ulnar arteries. As such, there is necessary collateral circulation between recurrent vessels and collateral vessels. The recurrent vessels are those which turn back onto themselves and head proximally, whereas collateral vessels run in parallel to the main vessels. So here's the radial collateral vessel running distally, and here's the recurrent radial artery running proximally. The same is true on the ulnar side. There's an ulnar recurrent artery originating from the ulnar artery, heading back proximally to anastomose with the superior and even the inferior ulnar collateral arteries. Notice how the ulnar vessels course behind the medial epicondyle, whereas the radial vessels course anterior to the lateral epicondyle and the capitulum. In lab, you are likely to see these recurrent and collateral vessels, but don't make them a top priority for your dissection. In order to supply the deep aspect of the forearm, the ulnar artery gives off a common interosseous artery, shown here. And the common interosseous artery further divides into an anterior and posterior interosseous artery. Here you see the anterior interosseous artery coursing just anterior to the interosseous membrane, which is shown here in white. Notice how the posterior interosseous artery courses deep to the interosseous membrane. The posterior interosseous artery therefore supplies the extensor compartment of the forearm. The anterior interosseous artery will supply the deep muscles of the flexor forearm. Now let's take a closer look at the osteology of the forearm. The ulna, shown here by the X, is the stabilizing and stationary bone of the forearm. Distally, the radius will pivot around the ulna during pronation and supination. When the radius crosses anterior to the ulna, that's referred to as pronation. And when the radius comes to lie in parallel with the ulna, that's referred to as supination. Again, the ulna is positioned on the medial side of the forearm, and it is the longer of the two forearm bones. At the distal ulna is the styloid process of the ulna, shown here. This is that bump on the back side of your wrist that you can easily palpate. Also note that the distal radius has a styloid process as well. This too can be palpated along the lateral wrist. Here's a better view of both the styloid process of the ulna and the styloid process of the radius. Between the radius and the ulna is the interosseous membrane, which separates the anterior from the posterior compartment of the forearm. I'll abbreviate this IO membrane for interosseous membrane. And extending from both the radius and the ulna are intermuscular septi, Here's the one from the ulna shown here. Here's the intramuscular septum from the radius shown here. And these intramuscular septi connect to the antebrachial fascia of the forearm. In this cross-sectional view, the antebrachial fascia is shown by the purple outline here and the green outline below. Because both the anterior and posterior compartments of the forearm are enclosed by very taut antebrachial fascia, fluids and infections are usually contained and do not spread to other compartments. Do recognize that a condition called compartment syndrome can occur when there is a significant buildup of pressure from bleeding or swelling of tissues within a muscular compartment. Because the tough antebrachial fascia is not distensible, the increase of pressure within the compartment can decrease blood flow to the muscles and to the nerves, depriving them of nourishment. This often leads to the 5 key signs of compartment syndrome, which include pain, pallor, which is a paleness of the skin, paresthesia, which is the numbness and tingling, pulselessness, or a weak thready pulse, in addition to paresis or paralysis. A procedure called a fasciotomy can be used to treat compartment syndrome. During a fasciotomy, the surrounding fascia of the inflamed compartment is incised in order to reduce the compartmental pressures. The forearm is merely one example where compartment syndrome can occur. Other common areas include the arm, the thigh, and the leg. Just like the organization of the arm, muscles with a similar purpose and innervation are grouped together in the forearm. The anteromedial compartment, which is that compartment outlined here in purple, is responsible for housing muscles which will flex the wrist and the digits, which are the fingers. The flexor muscles have about twice the bulk and strength of the extensor muscles in the posterior forearm. The flexors and pronators of the forearm are served mainly by the median nerve, encircled here. The median nerve will innervate all of the muscles of the forearm except for 1.5 muscles, which are innervated by the ulnar nerve, shown here. The posterolateral compartment, which is surrounded in green, comprises the extensor forearm, which is going to be responsible for extending the wrist and the digits. It will also help to supinate the forearm. And notice that the extensor compartment of the forearm is served by the radial nerve, encircled here. Let's quickly label these nerves: radial nerve, ulnar nerve, and median nerve. The focus of the remainder of this presentation will be on the 8 muscles of the flexor compartment of the forearm. These muscles are organized into a superficial, intermediate, and deep layers. The superficial layer of the flexor forearm contains 4 muscles. 3 of these 4 muscles arise from the common flexor tendon shown here, which attaches to the medial epicondyle of the humerus at the tip of the arrowhead. And here's another view of the medial epicondyle. The muscle which is the exception is the Pronator teres muscle, which happens to have 2 heads. The larger and more superficial head, which is referred to as the humeral head, as shown here, will attach to the supracondylar ridge, the medial supracondylar ridge. The smaller and deeper head of the Pronator teres muscle, shown here, which is referred to as the ulnar head of the Pronator teres, arises from the coronoid process of the ulna. By way of relationships, notice how the median nerve shown here passes right between these 2 heads. It passes superficial to the deeper ulnar head, but passes just deep to the humeral head. As its name suggests, the Pronator teres muscle is responsible for pronating the forearm. As such, it acts on the radius. The muscle belly of the flexor carpi radialis muscle, shown here by the X, is positioned just medial to the Pronator teres. The long tendon of the flexor carpi radialis muscle crosses the wrist joint and the carpal bones to attach to the base of the second metacarpal, as shown here. As its name suggests, the flexor carpi radialis muscle flexes the wrist on the radial side. In addition, it will also perform radial deviation of the hand, which is also known as wrist abduction. This means that the wrist, from the perspective of the anatomical position, moves away from the midline. Next to the flexor carpi radialis is the muscle belly of the palmaris longus. The long, slender tendon of the palmaris longus blends with the palmar aponeurosis of the hand. The palmar aponeurosis is a very strong and well-defined partition of the deep fascia of the palm. The palmar aponeurosis covers soft tissues of the hand, and it overlies the flexor tendons, helping to protect the palm of the hand from penetrating injuries. Interestingly, about 10 to 15% of the population lacks a palmaris longus muscle and tendon. Here's a brief demonstration. If you touch your thumb and pinky together and slightly flex your wrist, there will be a visible tendon just underneath the surface of the skin in the midline of the forearm. If this tendon pops out, then you have a palmaris longus tendon and muscle. If you don't visualize this tendon, then that suggests that you're part of that 10 to 15% of the population which lacks a palmaris longus muscle. All three of the muscles just discussed, the Pronator teres, the flexor carpi radialis, and the palmaris longus, are all innervated by the median nerve. The fourth muscle of the superficial group of the flexor forearm is innervated by the ulnar nerve, and this muscle is called the flexor carpi ulnaris, as shown here. The flexor carpi ulnaris originates from the medial epicondyle through the common flexor tendon, just like the other muscles. It too crosses the wrist joint, and as such will participate in both wrist flexion as well as ulnar deviation. Ulnar deviation of the hand is also referred to as wrist adduction, in which case the wrist, within the anatomical position, moves closer to the midline of the body. There is only one muscle that comprises the intermediate layer of the forearm. This muscle is the Flexor Digitorum Superficialis. Oftentimes I will abbreviate this muscle FDS. The Flexor Digitorum Superficialis is capable of flexing each finger it serves independently. The FDS spans from the common flexor tendon, shown here, to the oblique line of the radius, from which its radial head originates. The four tendons of the FDS cross the wrist joint. They also cross the MCP joints, the metacarpal phalangeal joints, and they also cross the pip joints, the proximal interphalangeal joints of the fingers, just before inserting onto the middle phalanx of the four fingers. Here's the middle phalanx of each finger. Notice how the FDS inserts onto that phalanx. Because a muscle can act on any joint that its tendon crosses, the FDS is capable of flexing the pip joints, is capable of flexing the MCP joints, and is capable of flexing the wrist joint. For the purposes of your upcoming dissection, in order to visualize this muscle, you will first need to shave away the Pronator teres from its radial attachment. Recall the Pronator teres was sitting just superficial to the radial head of this muscle. In addition, in order to visualize the muscles of the deepest layer, you will need to cut the FDS right here along its oblique line of the radius in order to visualize the deeper muscles. Because the common flexor tendon attaches to the medial epicondyle, this can be a site of inflammation, especially upon repetitive overuse of the flexor muscles. This is referred to as golfer's elbow, or medial epicondylitis. Not only does inflammation around the medial epicondyle cause localized pain, but patients can also present with paresthesia of the medial forearm and hand, as well as weakness in their grip. These particular signs and symptoms can be explained by the fact that the ulnar nerve can be affected in this condition. Notice how closely it passes around the posterior aspect of the medial epicondyle, here near the common flexor tendon, and the aponeurosis that connects the flexor carpi ulnaris to the common flexor tendon. This tunnel through which the ulnar nerve is passing is referred to as the cubital tunnel. Inflammation around the site of the cubital tunnel can cause the signs and symptoms previously described. And just for fun, I'll also mention that when you strike your funny bone, you are in essence pinching the ulnar nerve just posterior to the medial epicondyle. This is why you feel either pain or a pins and needles-like sensation which radiates down the medial half of the forearm and even into the medial hand. That's because that's the area of distribution served by the ulnar nerve. The deepest layer of the forearm is comprised of three muscles, the most prominent of which is the Flexor Digitorum Profundus muscle, abbreviated FDP. This muscle attaches to both the ulna, as shown here, as well as to the interosseous membrane, and it sends its four long tendons to cross the wrist joint, to cross the MCP joints, to cross the PIP joints, and to cross the dip joints. In other words, the tendons of the FDP insert on the distal phalanx of the four fingers. As such, the Flexor Digitorum Profundus is said to flex the fingers at the dip joints. What is unique about the Flexor Digitorum Profundus muscle is that it receives dual innervation. Its radial half is innervated by the anterior interosseous nerve, which is a deep motor branch of the median nerve. I'll draw in a stippled line indicating both the radial half and the ulnar half of this muscle. Again, the radial half is served by the anterior interosseous nerve, abbreviated AIN. And the medial half of this muscle is served by the ulnar nerve, as shown here. Knowing the specific innervations of these muscles will be very important when we start to localize nerve lesions that affect either the forearm or the hand. The second muscle of the deepest layer of the flexor compartment is the flexor pollicis longus muscle, shown here. The flexor pollicis longus muscle originates from the radius and it sends its tendon to attach to the distal phalanx of the thumb, as indicated here. As its name suggests, the flexor pollicis longus will flex the thumb at the interphalangeal joint, as well as at the MCP joint. And by the way, the word pollicis refers to thumb. Lastly, the pronator quadratus muscle is the deepest muscle of the flexor compartment. It looks like a bracelet cuff surrounding the distal forearm. Notice the orientation of its muscle fibers. They run horizontally in comparison to the vertical orientation of the other muscles. In addition to pronating the forearm, the pronator quadratus also helps to hold the radius and ulna in contact with one another at the distal radial ulnar joint. And just like the other muscles of the deep compartment, the pronator quadratus is also innervated by the anterior interosseous nerve. Again, all the muscles of the deep compartment are innervated by the AIN, except for the ulnar half of the flexor digitorum profundus, which again is innervated by the ulnar nerve. Before moving on, I want to take a closer look at the tendons of the FDS and the FDP. Notice that the tendon of the FDS lies superficial or anterior to the tendon of the FDP, which is shown here. As the FDS tendon nears its insertion onto the middle phalanx in this area here, it splits into two bundles, and passing through that split is the FDP tendon on its course to insert onto the distal phalanx, shown here. In order to test the function of the FDS muscle, 3 of the 4 fingers are immobilized in an extended position. By extending 3 of the 4 fingers, you are inactivating the FDP muscle. Notice that there is no flexion at the dip joint when the mobile finger is flexed. Here we have the dip joint, where no flexion is occurring, but flexion still occurs at the PIP joint and at the MCP joint. The fact that we have flexion at the PIP and MCP joints indicates that the FDS muscle is working. By immobilizing the pip joint of a single finger, you are now able to test the action of the FDP muscle at the dip joint. Recall that only the FDP acts on the distal interphalangeal joint, shown here. The flexor retinaculum plays a very important role in helping to secure the tendons of these various muscles. The flexor retinaculum, also called the transverse carpal ligament, as shown here, is a very strong, fibrous band of connective tissue that arches between the carpal bones and forms the roof of the carpal tunnel. Here's the flexor retinaculum from a slightly different perspective, forming the roof of the carpal tunnel. Next time, we'll look more closely at the carpal tunnel, but for now, realize that passing through this tunnel is the median nerve, shown here in yellow, along with 9 tendons of the flexor muscles. For now, simply appreciate that the flexor retinaculum prevents bowstringing of tendons, holding those tendons in place during flexion of the wrist and the fingers. Let's review the innervation of the forearm. Recall that the median nerve innervates all of the muscles of the forearm, except for 1½ muscles which are innervated by the ulnar nerve. The ulnar nerve will innervate the flexor carpi ulnaris muscle, as well as the medial half of the flexor digitorum profundus muscle. All of the other muscles of the flexor compartment of the forearm are innervated by the median nerve, or a branch of the median nerve. More specifically, the flexor muscles of the deep layer are innervated by the anterior interosseous nerve, as shown here. The anterior interosseous nerve branches high in the proximal forearm near the radial tuberosity, and it innervates the radial half of the flexor digitorum profundus muscle. It also innervates the flexor pollicis longus, in addition to the pronator quadratus. Now let's begin to apply what you have learned. Let's suppose that we have a patient who received a transverse laceration to the cubital fossa. The laceration was so deep that it completely severed the median nerve. How will this patient present clinically? When you ask the patient to make a fist, the patient presents with a benediction hand, as shown here. In other words, the patient is unable to flex the index and the middle finger. Why is that? Recall that flexion of the fingers at the MCP, the pip, and the dip joints is accomplished by both the FDS and the FDP. And recall that the median nerve innervates the FDS, and the FDP is half innervated by the anterior interosseous nerve, a branch of the median nerve. You'll notice from this presentation that flexion of the pinky and ring fingers is intact and is normal. This is because the ulnar half of the FDP is innervated by the ulnar nerve. Since the ulnar nerve was not affected in this injury, then the ulnar half of the muscle is able to flex the pinky and ring finger. However, since the median nerve was injured, the index and middle finger, as well as the thumb, are no longer able to be flexed, because the FDS has been compromised and the nerve innervating the FDP has been compromised. It is also possible in this patient to visualize atrophy of the thenar eminence in this area here. This is because this area of the palm is also supplied by a branch of the median nerve. So in summary, compromise to the median nerve in the cubital fossa can cause a number of downstream deficits in both the forearm and the hand. It is also possible to have entrapment of the anterior interosseous nerve. If a patient can make an OK sign, this tells you the anterior interosseous nerve is intact. This is because flexion at the dip joint of the index finger is accomplished by the flexor digitorum profundus muscle, the radial half specifically. Additionally, flexion of the interphalangeal joint of the thumb is accomplished through the flexor pollicis longus muscle. And again, recall that both of these muscles are innervated by the anterior interosseous nerve. When these muscles are denervated, the patient can no longer flex the index finger at the dip joint and can no longer flex the thumb at the IP joint. And as such, the patient presents with a flattened finger and thumb. Another way to test for this syndrome would be to ask the patient to pinch a piece of paper between his or her index finger and thumb. The physician should not be able to pull the paper from their grasp. This is because flexion at the dip joint of the index finger and flexion at the IP joint of the thumb is critically important for increased grip strength. If the anterior interosseous nerve is compromised, the patient would not be able to hold on to that piece of paper because grip strength would be greatly diminished between the index finger and the thumb. Lastly, let's review the cutaneous innervation of the anterior forearm, and let's also review the vascular supply of the anterior forearm. The anterior forearm is supplied with cutaneous innervation by two separate nerves. The lateral cutaneous nerve of the forearm, shown here in purple, is the terminal continuation of the musculocutaneous nerve, which, as you may recall from last time, that nerve was responsible for innervating the muscles of the arm. The area of skin, indicated here in purple, represents the distribution of the lateral cutaneous nerve of the forearm. And because the musculocutaneous nerve arose from C5 and C6 levels, so too does the lateral cutaneous nerve of the forearm. The second nerve providing cutaneous innervation to the anterior forearm is the medial cutaneous nerve of the forearm, shown here in light blue. This nerve arises directly from the medial cord of the brachial plexus to innervate the area of skin indicated here. And recall that the medial cord of the brachial plexus arises from the C8 and T1 cord levels. And realize that the closer you get to the midline of the forearm, the more overlap there is between the cutaneous nerves. That being said, if you needed to clinically test one cutaneous region versus another, you would never want to test in the midline of the forearm because of the overlap. Instead, you would test on the medial side or on the very lateral side of the forearm. Not only do the median and ulnar nerves carry motor fibers to the forearm, but these same nerves also carry sensory information back from the hand. The medial side of the hand, including the pinky and half of the ring finger, are innervated by the ulnar nerve, which again comes from C8 and T1. The majority of the rest of the palmar surface of the hand is cutaneously innervated by the median nerve. Lastly, let's briefly review the arteries of the forearm. Recall that the brachial artery bifurcates here within the cubital fossa into the radial artery on the lateral side and the ulnar artery on the medial side. Eventually, the ulnar and radial arteries will anastomose with one another here in the palm of the hand as the superficial and deep palmar arches. Also recall that in the cubital fossa, the ulnar artery gives off a common interosseous artery. Sometimes this branch is very short. The common interosseous artery gives rise quickly to a posterior interosseous artery, which supplies the extensor compartment of the forearm, and the anterior interosseous artery, which will supply the deep compartment of the anterior flexor forearm. This concludes this presentation. Thank you for watching and happy studying.